We're Team 6, and this is our eczema case presentation. Aim is a 32-year-old male who presented to the pharmacy looking for a recommendation on over-the-counter medication to treat his eczema until he meets with his dermatologist next month.
M is a 32-year-old male. He reports that eczema flare-ups are common in the summertime. Currently, he has red, itchy patches on his arms. Currently, he has treated these with wet compress and lotion. He has a dermatologist appointment in 1 month. M currently takes loratadine for seasonal allergies. M has asthma, which is controlled by an Advair discus and an albuterol inhaler. M also takes a general multivitamin for general health. Medication experience, marital status, insurance status, and social history are currently unknown. M has no known drug allergies, no known adverse drug reactions, and no known alerts.
Here are his current medications. For seasonal allergies, M takes loratadine 10 mg tablets. He takes 1 tablet by mouth every day. For general health, he takes 1 multivitamin tablet by mouth every day. For asthma, he takes 1 puff of his Advair discus, 100 microgram over 50 microgram by mouth twice daily. Another thing for asthma that he takes, this is his rescue inhaler, albuterol 90 micrograms. He'll take 2 puffs by mouth every 4 to 6 hours as needed for asthma. Upon interacting with Mr. M, we observed red patches on the skin of his inner arms.
So our patient's indication is eczema, and we have 2 goals of therapy. The first goal is reduced redness and itchiness due to eczema from moderate to mild in 1 week. Our second goal is to reduce redness and itchiness from mild to none until M is able to get to his dermatologist in 1 month. Our drug therapy problem is indication needs additional drug therapy. M is in need of additional drug therapy to treat his itchy, red skin caused by eczema. We have 3 therapeutic options. Our first option is topical corticosteroid, hydrocortisone 0.5% ointment, pending no open sores. Our second option would also be a topical corticosteroid, a 1% ointment. And our third option would be an antipyretic, acetaminophen 325 mg caplet.
The review of systems. Relevant systems are the nose, skin, and pulmonary. In the nose, M talks about having stuffiness and a runny nose. Both of these are well controlled by loratadine. For the skin, he has rash, itching, and dryness. For pulmonary, he has difficulty breathing and wheezing, and both of those are well controlled by Advair. The plan for M. For the indication of seasonal allergies, he will take loratadine 10 mg tablets. The instructions are to take 1 tablet by mouth every day. There are no changes that were made to this medication. For general health, M takes a multivitamin tablet of unknown strength. He takes 1 tablet by mouth every day. No changes were made to this medication. For asthma, he will continue to take Advair discus, 100 micrograms by 50 micrograms. He will inhale 1 puff by mouth twice daily. No changes were made to this medication. Also for asthma, he takes albuterol 90 microgram inhaler. He will inhale 2 puffs by mouth every 4 to 6 hours as needed for asthma. No changes were made to this medication. For eczema, he takes hydrocortisone 0.5% ointment. He is instructed to apply sparingly to affected areas 3 to 4 times daily as needed. This is a new therapy, and on the next slide, we will explain the rationale.
Our rationale for choosing the hydrocortisone ointment would be due to the American Academy of Dermatology guidelines. They recommend that a topical corticosteroid as the first-line therapy for atopic dermatitis flares. We chose to start with the lowest concentration available to lower the risk of side effects. If this dose is not effective, we can try a higher strength. If M does have open sores, topical corticosteroids would not be the preferred option. For some non-therapeutic interventions, we recommend that M consider following up with his dermatology doctor to conduct a skin patch test to look for allergy triggers. We also recommend that he starts an itch diary where he can log when, where, and what happens when the skin flare-ups occur. He can also measure the area of his eczema, and by measuring and logging his measurements, he can determine if it's worsening or not. Maintaining skin hydration is recommended. He can do this by using moisturizers after bathing and by drinking plenty of water. We also recommend that he avoids and minimizes factors that aggravate the skin condition. This includes known contact allergens and foods that can trigger the flare-ups.
Patients should also consider using cotton sheets washed in gentle detergents with a second rinse cycle. Liquid fabric softeners are preferred over dryer sheets. Bathing in tepid water with mild non-soap, fragrance-free cleansers for 3 to 5 minutes can help hydrate the skin every other day. Patients should also consider cotton clothing. Ultraviolet light therapy can also be used after failed moisturizer and topical steroids therapy like hydrocortisone. Patients should also use sunscreen when going outside. Avoid sunscreens containing zinc or titanium. M should also avoid scratching inflamed flare sites to avoid secondary infections. He should also keep his nails clean and trimmed. We will have a couple of different follow-ups, all that will be conducted over the phone. On day 1, safety will be evaluated to make sure M is not experiencing a worsening of symptoms and/or an allergic reaction. In 1 week, we will also call to ensure safety and effectiveness of therapy. Safety will be evaluated over the phone to make sure M is not experiencing worsening of symptoms and/or allergic reactions. We will also evaluate effectiveness to make sure that M's symptoms have improved by reducing itching and redness. In 1 month, we will also call to ensure safety and effectiveness. With safety, we will evaluate over the phone to make sure M is not experiencing worsening of symptoms and/or allergic reactions. We will also be evaluating effectiveness to make sure that M is no longer having any eczema symptoms, itching, or redness.
And finally, we'll end it with what questions we'd like to ask M. Firstly, what drug intolerances M has, if any. Historically, where M's eczema has been located on the body. If M has any open sores. What else M has tried in the past to treat the eczema. And then also M's social drug history, including caffeine, smoking, alcohol, and any recreational drugs. And finally, our references page. A very big thank you for watching our presentation on behalf of SEAL Team 6. Have a good day.